Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I am with Brett and Sean. How are you guys doing today?
Good. How are you doing, Dennis?
Doing great, Dennis.
Perfect. So you guys are coming to us from Alaska, and you teach, is it the Arctic Warfare course, Brett?
Yeah, so it's the Arctic Medic course, or we've also nicknamed it the Combat Medic Arctic Trauma course.
Okay, perfect. So, which is super convenient because that's what I'd like to talk about, because after the first Arctic PFC podcast we did, I was definitely left with a lot of questions, and I understand that it's a completely different environment from what I'm used to, but there's definitely some things that I kind of felt like couldn't or shouldn't be holes in my knowledge, if that makes any sense. So I definitely wanted to reach out to you guys to hopefully get those questions answered.
Yeah, absolutely. And this has just been a really neat program to put together over the last really like 6 months or so, with a lot of great input from really across the DoD and even outside of the DoD as well. But I will be frank with you too, though we still have a lot of questions that we are trying to work on getting answered as well. So
yeah. So since this is both of your first time on our podcast, Brett, why don't you start off? If you could give us just a little bit of background about yourself.
yeah, sure. So I'm currently the brigade PA up here for First Brigade, 11th Airborne Division Arctic. We well, I initially got up here about 2 years ago, and this was my first duty station as a PA. Before becoming a PA, though, I was actually an 18 Bravo, or a Special Forces weapons sergeant, and then a intelligence sergeant in 10 Special Forces Group down there at Fort Carson in Colorado. I did 9 different deployments with them all across Iraq, Afghanistan, Tajikistan, and then quite a few different trips to Africa, and was also the master mountaineer for my team. And it was a really neat opportunity for me to come up here and apply what I loved with the mountains and with mountain medicine, and apply that up here to the Arctic, and really get started with this course up here.
Perfect. Sean, how about you?
Yeah, I'm Staff Sergeant Sean Potter. So I'm with the 1st Brigade, 11th Airborne Division. This is actually my second time up here. I was actually stationed at Fort Wainwright 2015 to 2018, where I was able to become a line medic at an infantry battalion, move my way to the senior line medic, did the job of an evac NCO, and then the treatment NCOIC. On this tour around going through Fort Wainwright, I was stationed with the 25th BSB, where I was the treatment platoon sergeant. And now I'm actually dedicated to this program. A little background on my experience: I've gone through all of the NWTC, the Northern Warfare Training Center schools, the Cold Weather Leaders course, the basic and advanced mountaineering courses. I'm also on the Denali team in order to summit Mount Denali this year, and had the opportunity to go to Norway to also train with our NATO partners as well.
Perfect. So you guys are definitely very well rounded in this environment, I think. Why don't you, Sean, if you would, why don't you start us off about telling us about your course?
So our course right now is a 4-day POI. We found the necessity to train the brigade medics in this environment because there was a lack of what the units were doing. So with a lot of provider input, that's where that medical knowledge starts to come into play. And I don't want to steal Brett's thunder here, but I'll let him speak more on that. But we wanted to develop a course that didn't recreate the wheel. It was one, how do we utilize the equipment that we're currently fielded in order to sustain casualties in this environment? How are we troubleshooting our equipment, what works and what doesn't work, and then providing solutions for medics to emulate and critically think through in order to help casualties.
Perfect. I mean, that sounds like a lot crammed into 4 days.
Yeah, it really is. And I think, actually talking through our POI, Sean would be a great individual to do that with. But just from the provider perspective up here, one thing that we were seeing was just there was a pretty significant amount of cold weather injuries, whether that was frostbite, trench foot, carbon monoxide poisoning, these kind of things that we identified as issues up here, that we wanted to create a course that would both address the changes that need to be made with TCCC as it applies to the Arctic, but also, hey, this is a fight that we're in every day with the weather up here, and we want to be able to prepare the medical professionals to be able to identify, prevent, identify, treat these things that we're faced with every day.
Nice. How long has your course been running, Brett?
So we started really in about December was the first iteration of the course, and then we've run 6 iterations since then.
Nice. It's probably pretty soon to actually measure if there's any change in the culture, I guess, or as far as the medical staff goes. But have you noticed any kind of reduction as far as cold weather injuries due to education?
Yeah, I would absolutely say that that's happening already, and it's been really neat kind of to see it from both ends, because one of the biggest things that we try to preach with this course is that, hey, these combat medics are at the lowest levels of these infantry platoons, and so what they have the ability to do is, having these 10-man tents, cycling soldiers through their 10-man tents, pulling the boots off, checking their feet, and doing that daily. That's had a huge effect. But not only at that more tactical lower level there, but the top level leaders are also holding those company commanders and first sergeants accountable too, and making sure that from that end they're also checking these soldiers' toes and their feet, and it really truly has had a great effect already.
So, Sean, other than TTPs as far as identifying things, have you guys figured out any life hacks when it comes to treating cold weather injuries?
Yeah, a lot of that does boil down to that preventative medicine. Just having that knowledge of key leaders. We go through in our course what's called a Siberia drill. So in the cold weather leaders course at NWTC, it's a very brushed on, brief check. Hey, I just want to make sure that your hands and feet are good, but they're not getting into the weeds of how a normal medic should actually talk to the soldier and build that rapport and make sure that they get these answers out of the soldier. But the Siberia drill is something that I learned in Norway, and across NATO is pretty recognized. The Finnish use it, the Canadians use it, and it's just a more in-depth check to see the well-being of a soldier and being able to undress and redress, get people out of wet clothing, put them in dry clothing. That is the biggest thing that's changed, is being able to have medics be trustworthy to get those checks done. Other life hacks, just on a small scale, would be being able to utilize equipment that you're using in your own packing lists. I can only speak for the Fort Wainwright CIF, but you get fielded a Nalgene bottle, and with that Nalgene bottle comes a insulated cover that you can put it in. And that routine of always having boiling water in there to put with your hypothermic patient in between their legs into their armpits has actually made a huge difference on active rewarming for our patient.
Nice. Would you mind doing a quick run through of that Siberian drill? Right.
So it starts on identifying where where I'm at in the battlefield right now. Usually, you don't want to do this maybe directly after a tick or whatever going into an objective. That's the wrong place, the wrong time. Prior to a movement, I want to get a baseline, just understanding who your soldiers are, how they interact with you, on that general well-being of the person. And then based on my experiences, a lot of the infantry battalions are moving with an 80-pound rucksack as it is through waist-deep snow, carrying a 300-pound Accio behind them. So that's going to take a lot out of the soldier. Once you in place your OP, then you get into that 33% security. You can start rotating those people in and out to get with the medics. So the first thing you would do is taking that insulated pad or maybe a rucksack in order to have that soldier sit down on them, so that you're treating for that conductive heat loss from the ground. They're not just sitting on the ground with their boots off. A very brief head to toe is checking for those white spots. Do I have that? Do I have that start from chilblains to frostbite? Because if I can identify that it's just chilblains, it's very easy to just put skin to skin on it and rectify that very quickly. Understanding where they've moved through. It's not always negative 30 degrees here, but you have snow on the trees. You have that non-freezing temperature where you're still walking through heavily wooded areas, and that snow is starting to pile on the soldier. They're getting sweaty. It's running down the back of their neck. It's soaking their boots. Just being able to identify things like that and making that medical decision, hey, before you become a casualty, I need to change you into these things. And then monitoring their ins and outs. A lot of that boils down to the team leader, squad leader. So that's why the Siberia check should be something that the medic takes back to their unit and trains up the squad leader, team leader to do. But when's the last time they ate food? When's the last time they drank? So that we can start preventing these things rather than being reactionary medics for this environment.
Nice. Obviously, you're going to repeat that after movement or after things have died down for whatever action you've been doing. And so now that you have a baseline, then you can check for any kind of changes. Is that the idea?
Absolutely. And then we're gone past the days of everybody that's cold needs to be evac'd, because that's not the case. You can implement things as far as rewarming drills. If I identify a chilblain or a white spot on the skin, you have to document that, but also have that follow up with the soldier. Don't just say you're good to go, and then 2 hours later with no recheck, now they have a bigger problem. You always want to have that follow through when you identify things, and then make the call when it's a medical emergency.
Yeah. So, frostbite, chilblain, trench foot or immersion foot, all super common. But I think one thing that probably scares most of us is having to do, T-TRIC or march in that kind of environment. And so in the last podcast, they were mentioning essentially they're doing hemorrhage control and then moving to some kind of shelter, whether that be something that's pre-made or something that's probably improvised. And one of the questions that I had was in the area of airway management. Now, they had mentioned that it's probably not safe to take a patient's airway, like a definitive airway, like a crike, in an Arctic environment. But certain injury patterns, wound patterns, you're going to have to, or the patient will just suffocate. So have you guys kind of practiced that or talked about that and came up with a solution? Brent?
Yeah. So yes. So and I don't want to say yes as in we have a solution, because I would agree with our our brothers and sisters down there with 211 that you had on a couple of weeks back. This is just a tough environment in general. There are challenges that are created with this environment that you just can't experience without being up here, and you know the way that the cold changes things, it truly is incredible. But one thing that we've really had to do is consider, how does this affect our triage categories too. So some of these um, patients that you know could potentially be up categorized within triage. That's something that we had to look at too. But we have worked through some of the dexterity issues, and that's like putting gloves on over top of our contact. So actual, you know, surgical gloves on over top of our contact gloves to be able to perform these surgical techniques out there. And it is challenging. And I don't want to say that we have a better solution, but truly the best solution is getting them back into one of those 10-man tents, or some of the more some of the different options that we have to get them into an actual shelter before we perform those interventions.
Okay. So, I mean, I guess, the whole point of the podcast is to ask the hard questions. What if I do have to take somebody's airway because they have a mechanical obstruction? Um, you know, Obviously, good thing he's now able to breathe. Bad thing, he's getting Arctic air directly into his lungs. So, I guess, do you know what kind of things I can expect to have happen, Brett?
So, initially, what I would expect would be a pulmonary edema, and then essentially a worsening of the effects that hypothermia may already be having on that patient. But that's where we've been looking through some techniques to potentially chamber and warm that air as it goes down, like through the packaging of the patient, or their whether it's in the HPMK or the actual hypothermia wrap that we teach in this course here, actually running more tubing down through, so it's actually chambered and warmed by the patient itself, and then returned to the patient, so that we avoid those things like the pulmonary edema or other issues that may arise from all that cold air going into the patient.
Okay. All right. That definitely makes sense. How long is that tubing that you're connecting to his airway?
Sean, would you want to speak to this? Because I know we were just chatting with this with our students up here this last week.
Right, absolutely. So it's pretty much the tubing that you would have from your Save 2 ventilators. Um, Being able to take that accordion tubing and throwing it in with an active heat source underneath some sort of insulative property, whether that's a sleeping bag, level 7 supplemented, inside of a hypothermia wrap. That way you're taking that active heat source plus the heat that the casualty is already producing, and then it's still filtering through into that patient. But pretty much the length of it would be the standard, maybe 3 feet of accordion tubing that you can either make smaller or longer as needed.
Yeah. Okay. So obviously, when we're talking about Arctic type environments, we're talking about like the negative 30, negative 40, or lower. So hypothermia management is, imperative. Other than the ready heat, which we know, like even in North Carolina, the ready heat isn't amazing, and it gets nowhere near that cold here. Have you guys come up with any other techniques as far as getting the patient, at least to stop the patient from losing heat, as far as using a ready heat in a HPMK and sleeping systems? And what have you guys cobbled together as far as your training course goes on how to do hypothermia management properly?
Right. So once again, outside of that hypothermia wrap, I'll just give a brief rundown what that would look like. Is you have a closed-celled foam pad underneath the patient to reduce that conductive heat exchange between them and the ground, and then supplementing with an HPMK. the ready heats, they do not work in extreme cold as far as fanning it out in the open air. What we have found out is after you've cracked it open and you place that with the patient, you're still going to need a little bit of humidity in order for that to kick on. It's not ideal because it doesn't turn on right away, but the humidity from that patient will actually activate that ready heat. The other thing outside of those insulative properties that you add on top with the sleep systems, maybe supplementing with level 7s as well, is utilizing those warm Nalgene's. Every unit is still being able to eat MREs, those cold weather MREs that you have to boil, whether that's jet boils, MSR stoves, melting snow on your SHA. Getting into that routine of always carrying warm Nalgene's, putting a warm Nalgene in between their legs and into their armpits is that active heat source that's on every packing list that you're going to use.
Okay. Have you guys gotten into some kind of active rewarming techniques? So off the top of my head would be like rewarming the Foley bag and then pouring that warm water through the Foley back into the patient and then letting that sit for, 15, 20 minutes and then draining the Foley back out. What have you guys trained or practiced with anything like that?
Yeah, so this is definitely something that we have not, actually tried doing on a patient. I just, fortunately for us, we've not had hypothermia patients come through our Role 1 as contrary to popular belief, folks are actually staying pretty well warmed out here with the clothing system that's been issued and with the shelter systems that are established that are part of the standard operating procedures of these maneuver elements up here. But these are all some great ideas that we would like to continue looking at and even adding into our course in the future. Because no, Dennis, those are fantastic ideas that we would like to consider and look at other ways too that we can improve that for folks.
Sean, did you have something to add?
Yeah, we kind of steer away from that thought process because one, that's very invasive, and two, the exposure time on having to check a lot of these things. So when we're talking about that -30 with a lot of wind, I'm having to expose my patient by uncovering them in order to do this procedure. They're going to lose a lot of heat. Is the risk versus reward going to be greater or less? And once again, like Brett was saying, we just haven't had that hands-on to actually test it.
Yep. No, that definitely makes a lot of sense. It's got to be some kind of give and take when it comes to, is it worth it for me to expose the patient in order to do this procedure? Or is it safer just to move out with a bit faster and get to some kind of shelter where I can do more thorough jobs as assessments, treatments?
Yeah, Dennis, and that's exactly right too, because a lot of times when we get these patients back to our Role 1, that's where we can really focus on that active rewarming of the patients, where those hypo wraps that Sean was talking about, those do a good job of at least keeping the patient from losing any more significant heat. But then we have these Drash heater systems that are that heat our Role 1s that we're actually able to really heat up our patients pretty well and actively rewarm them when they get to us here at the Role 1.
Since both of you have been up there for at least a couple of years, one thing I've found, I would say the newer generation of soft medics is kind of a lacking when it comes to survival skills as far as creating a fire, building a shelter, navigating without GPS systems. In your guys' experience, and I'll start with you, Sean, how important in going forward in the modern battlefield is it going to be to have these kind of old school survival skills?
Oh, absolutely. You're 100% right. Have the knowledge. Knowledge is going to be king out here. Even if you had all of the nicest equipment fielded, that's probably not been very, very well tested yet. To put into place and see if it's going to be effective might not be the best case. But having that knowledge of, as simple as I need a heat source. Where's that heat source coming from? Can I build a fire? Being able to, if my 10-man tent for some reason is unable to be used, whether I took indirect fire in my position now that 10-man tent is gone, where is my shelter now? Being able to build those structures is going to be key. And like I said, it boils down to that knowledge. You just have to have the knowledge versus what you're actually using as equipment.
Nice. Brett, Paul told me you're famous for the amount of hunting you do. Have you, what's your thoughts on those survival skills?
Oh, that's nice of Paul. Yeah, it is absolutely critical up here. And one thing that I would add to what Sean is saying there is, hey, look, like I mean, I spent almost 10 years on an ODA, and seeing the environment up here, you don't understand until you actually get boots on the ground here. So what I would say to the folks that um, especially in like the soft community, guys, come up here. You guys, you really have to experience what this winter is like here in November through the end of February. Often we'll get folks up here that want to come here in March or in April, and it's just not the same as when we're in these negative 40-degree snaps, and when you have to actually go out there and live in a snow cave for several days on end, or even operate these. Build these 10-man tents and operate the stoves that were issued up here. All that field craft that really comes into play huge up here. I can't say that enough, Dennis. That's a really good observation.
Obviously, the main focus is extreme cold weather, but it's only completely frozen half the year. Now I know in the Arctic, it's kind of famous for when the thaw happens, like black flies and mosquitoes and all kinds of other things come out. Have you guys looked at like how do you deal with all these black flies?
The incredible tool that we have up here. So not to get into too much hunting, but I sit on bear baits and hunt black bears and grizzly bears up here all spring. And if you do not bring these little thermocells, you'll just get eaten alive by those black flies and by those mosquitoes. But the thermocell is a really neat little tool that you can bring out there that packs it in your pocket, and it'll give you about a 5 foot buffer or so around your person, and it does a great job to where you can sit up here in a t-shirt in the springtime and in the summer when it's thawed, and those mosquitoes and all those other flies hit in real hard.
I've seen it a lot. I mean, North Carolina, when you especially get into swamps and things, I mean, the mosquitoes are horrible. And I'll see medics like dousing themselves with DEET or whatever other bug spray they bring, and then they completely forget about the patient, and they're just getting drained of all their blood because nobody bothers doing anything for the patient. But definitely one of those things that you got to keep in mind if you're putting bug spray on yourself or you're stoking up your thermocell for yourself. Definitely you gotta think about that patient that can't do anything for themselves.
Absolutely right. The one of the jokes up here always is the Alaska state bird is the mosquito. So
You, Brett, you kind of poked my interest. I'm going to come up there and operate. I'm going to do some training up there. What kind of things would you want me to prepare for before I get there?
the biggest priority of work that you have to be ready for is shelter. This is such a critical piece to obviously the most the basic part of this is prevention, right? So if we have a shelter that we can fall back on, that's critical. All the when you talk to the locals up here, that are running trap lines at negative 40 degrees here, they have shelters that they carry with them, but also established along the way because they just realize how critical it is and how impossible it really is to survive for extended periods of time without shelter when it's, again, negative 30 or negative 40 degrees. So before you come up here, just please, have a plan for the shelter before you are going to start doing, light infantry type operations.
Okay. I mean, is there any kind of criteria for that shelter?
Um, in particular, it would be great if you, especially in the wintertime, if you can come with a heating source. Now, we have some certain things in our course that we teach. It's because it's what we're issued. So we teach this Arctic 10-man tent and how to operate the stove, how to set it up. But I recognize that when I was on an ODA, I didn't have an Arctic 10-man tent. So the things that you could buy are simply like insulated ice fishing shelters. We show guys the Rigloo up here that they can set up, but these are just that's just a single wall tent. Um, but even having those shelters like you would use those insulated ice fishing shelters, you can heat those up pretty darn quick with just one of those buddy heaters. So just having a shelter and that external heat source that can warm you up and take care of your patients, that's critical.
Sean, what are your thoughts on shelters?
It's spot on with Brett. It is an absolute necessity here, because if you're just here in the mindset of a medic, thinking, oh, I can take my patient anywhere, and an evac platform's going to get them. Where are they pre-staged? Vehicles get stuck in the snow here, so it delays evacuation. Where am I gonna house my patients? But then it boils down to also, if I can't take care of myself, how am I going to take care of other people? So I have to be able to bounce back to some sort of shelter, because the exposure time out here would definitely cause injuries to just the individual.
Perfect. Alan, do you guys have any last thoughts?
Well, Dennis, yeah, since I got you, if you don't mind, I just would like to just give a quick overview of the course and just the 4 days that we currently have. And really that first day, we get folks in here, and the first thing that we do with soldiers is, hey, we run them straight through a trauma lane, and we show how really how the Arctic slows everything down when it's so cold out here. And it's kind of one of those gut checks that really identifies a gap that you may have that we hope to fix over the next, several days of the course. And then we spend pretty much all afternoon that first day learning how to use the flotation that we're given here in the Arctic, whether it's snowshoes or skis, and then how to establish the shelter. So that's that Arctic 10-man tent. That second day, we spent almost the entire day really talking through TCCC and how the Arctic alters what we would do as standard procedures for TCCC. The third day is really a provider heavy day where we talk real specific things that we experience as providers, and then as the medical professionals up here, and that's going through all the different types of cold weather injuries. I know the one thing that was always shocking to me was how much I see trench foot up here, and that's kind of a function of the boots that were issued up here. We get cold weather winter boots, but we also have these vapor barrier boots. They're also known as bunny boots. And while they're awesome for keeping feet warm, if you don't change your socks daily, you can just sit there and get these kind of soppy, wet feet. So seeing trench foot has actually been much more common to me even than seeing frostbite. I would say it's almost a 6-to-1 kind of a thing. But that third day, again, is just a very provider heavy day where we're talking about Arctic physiology, um, frostbite, trench foot, carbon monoxide poisoning. But then we're also talking about how do we take care of medications up here in the Arctic, and then we're actually doing uh, uh, some real world scenarios on those days too, like going through how to manage a hypothermia scenario patient, and then going through how to manage a frostbite scenario patient. And then that final day, we actually have a written exam and then a collex that we take these guys through over a several hour period. So I just wanted to give a quick overview of the course as kind of like a parting rundown of how it looks for folks if they're interested in attending.
Is your course an ATARS course? Can I look it up on ATARS?
So we are in the initial stages of development at this point. So it's not actually in ATARs yet. It's something that we're working towards. We're actually looking at nesting this course in the future in the Northern Warfare Training Center. But as of right now, it's simply run here at Fort Wainwright, and we can always have give some contact information if people are interested. They can reach out to us and find out how they can attend when we start these iterations when winter hits up here in Alaska in October next year or in later this year.
Sean, do you have anything to add?
I just wanted to touch base on a few of the differences. It's a lot of what we've already covered, but just that the utilization of that knowledge versus my equipment. We utilize a lot of the Skedco ropes in order to do improvised evacuation, utilizing your bivy sack, because I might not be able to carry 20 Skedcos, but every soldier in their packing list has a bivy bag in which I can utilize a rope system in order to attach to that bag and still be able to evac my patient, because it provides flotation over snow. And then going into the TC3 stuff, it just gives the nuances on that second day of what changed from TC3 to just our experience and our observations of how we're going to implement different techniques with the same knowledge we have as medics as a whole. And then once again, I think my biggest thing is that experience and knowledge will always be what you're going to bounce back to. You always want to get those repetitions in. You always want it to be second nature. So we do incorporate a lot of scenarios and hands-on time, incorporated with the didactic PowerPoints that we also have. So it's just ingraining and it's creating that routine and repetition rather than you see it once and then now I'll never see it again type of deal.
Perfect. Well, thank you guys very much.
Thanks for having us, Dennis.
All right. Thanks for having us, Dennis.
For today's podcast, be sure to go to our website, www.prolongedfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy, it's waiting there for you.